So we need to know about type 1 and type 2 process thinking. And what we've been talking about so far is system 1 thinking, which is intuition, gut reaction, blink. We use shortcuts, so that's heuristic. Doesn't take a lot of time, it's not very effortful, but it's affected by emotion and we make mistakes in system 1. If you take diagnosis as the exemplar, system 2 is where you take a full history, examine the patient, make a differential diagnosis, do some tests, refine your differential diagnosis. I'm just thinking of D-dimer. The D-dimer's 4,500, Dr. Nimmo. Well, why did you do it? It wasn't indicated. Similarly, troponin, but anyway. Start some treatment, see if the patient gets better. It takes a long time, it's systematic, we get a lot of information before we make our decisions, and it's very reliable. The problem is it takes time, and if you're working in a high pressure environment, which many of us are, with lots of patients to see, it's difficult to do this every single time. Fortunately, we can look at this in a nice, easy, understandable, systematic way. That's brilliant. So Pat Crosskerry has taken that psychology, cognitive psychology literature, which I described earlier on, and has assessed it for us, and has put it into 2 groups, and this is the same slide as earlier on. The group on your left is system 1 related, the group on the right is system 2 related, hypothetico-deductive reasoning, Sherlock Holmes, appropriate since Conan Doyle went to medical school here in Edinburgh for about 3 weeks and decided that writing books is probably the way to go. Unfortunately, if you look at the balance of the literature, the vast majority of research has been done in system 2, and we know that we spend most of our time in system 1. If you think about the last time you drove somewhere, suddenly you've gone a mile and a half and you haven't actually noticed where you've been, especially if you're round about where you normally live. So you've been driving in system 1 and you've been thinking in system 2. So you looked at the patient with shingles, you recognised that, and whew, immediately we've got that's shingles. We looked at the other patient. Why did you say meningococcal septicemia? The majority of people. You've seen it before. What about the Meningitis Research Foundation in the UK? They've got fantastic advertising. You see posters at bus stops, and they've got some really good teaching materials, and very happy to share those with you. There's an office here in Edinburgh. So there's what we might call an availability bias. It's something that's been shown to us. That's a bit like buying a new car and then seeing that half the population have got the same kind of car. So then there's, I don't know what this is, I'm going to have to spend some time working on it. Like the Siberian ruby throat, maybe. One of the interesting things, when you go back into your clinical practice and look at this and think about it, the way you're making decisions and the thought processes behind it, if you have experience and you use system 1, you'll get it right a lot of the time. So if I walk into the room and the patient, there's that sort of metallic smell, the patient's sweaty, they look shocked, they're tachypneic, tachycardic, and the blood pressure's 220 over 130, I'll say, I think this is left ventricular failure. I have to then calibrate into system 2 and say, could be a subarachnoid hemorrhage with neurogenic pulmonary edema. Has the patient got a headache? But you, seeing things that you've seen before, will use system 1 to the patient's advantage. The important thing is to recognise when you're in system 1, and if things aren't going the way you would expect them to say, oh, hold on a minute. So we had a 23-year-old Swiss lady who was across in Edinburgh learning English. She was doing English as a foreign language. Hadn't been into class for a couple of days, so her teacher went round to her flat and found that she was really quite unwell. Called the GP. You'll like this. So the GP comes to the flat and the teacher says, would you like a cup of tea? And he said, yeah, that'd be nice. So they sit for 10 minutes and have a cup of tea. It's on a Friday, sort of during the day. He then walks through the bedroom door and in his own words he said, oh shit, this lassie who's moribund lying in the bed. So he didn't obey what I call the 5-second rule, which is 5 seconds of looking at the patient is worth 10-15 minutes talking about them on the phone. He phoned me that evening to find out how she was getting on. Anyway, she came in, she had a rash which was similar to that. She was completely shocked. She had a respiratory rate of 40 odd, she had a heart rate of 170 odd in sinus rhythm, no pulses that you could feel apart from her carotids, still conscious, and really shut down. Ailsa Howie, one of our acute medicine registrars, was the first responder in the resus room and had got her cannulated, got some fluid in, lots of oxygen, got cultures off and said she's got meningococcal septicemia. Sounds fair. So we took her to ICU and put her on a ventilator and put lines in and all that stuff. So I was doing my calibration, which is I sit at the end of the bed and when I'm writing in the notes I look at the 4 H's and the 4 T's in our handbook and say, is there anything I've missed? Chest X-ray, ECG, bloods, just make sure I haven't missed anything. And I looked up. This is really strange. So she's nice and settled on the ventilator, good blood pressure, heart rate's down to 120, still completely mottled, but her face was pink. It was as if she had this aura. It's bizarre. Her face, from there up, she looked pink and everything else was still blue and mottled. Any ideas? So I said, can we check and see if she's got a tampon? She had staphylococcal toxic shock syndrome. And it just didn't look right. And that's what that toggle function's about. It's about looking at your patient once you've started to, and going back and saying, are we sure that we've got the right answer here? So we modified her antibiotics and eventually she did fine. But it's that calibration, giving yourself a bit of breathing space to go, we've made a lot of decisions in System 1 here. Let's stand back and see. So coming back to my comments about getting the system right earlier on, if you look at system-related diagnostic error, it's only about a fifth are due to the system. So your radiology department or your biochemistry department. That's important. But if you look at the combination of thinking issues and thinking and system issues, you're talking about almost 3/4 of diagnostic error involve thinking. And there's nothing that a systematic thing can do about that. It has to happen internally to make it better. So we've talked about the toggle function. Practice, if you're a concert pianist or a chess grandmaster, the psychologists say you need 70,000 hours of practice to get to that level. You can do that in your home. What we do, you can't do in your home, and with contraction of hours, reduced number of patient contacts, particularly for medics, we have to find other ways of getting that repetitive practice experience. And then there's the cognitive miser function. Our brain wants to be in System 1 because it doesn't use as much energy or it's easier. So we have to be aware of that. But this isn't just a theory. If you put somebody into a brain scanner which can look at which parts of the brain are working, positron emission tomography or MRI scanners that can do this, System 1 and System 2 are actually anatomically distinct in the brain. And you can say, well, system 1, you don't have to think about it. So that's your, it's like, oh, if there's a rhinoceros running towards you, or a 26 bus, you don't have to think about getting out of the way. It's a survival thing, which is why it's automatic. Anyone read either of these books? Blink. So Blink is about system 1, Think is about system 2, and what you really need to do is to get the compendium. We think in system 1, we think in system 2, we need to know how they relate to each other and make ourselves go into system 2 when it's appropriate. Blink's quite enjoyable, easy read. I'm sure that guy at the left-hand side was one of our SHOs. He's the one who used to go home during the night when he was on call. This is being recorded. Okay, what does that say? United States Senator. So you see what you think you're going to see. Your mind's already made up. Which table's longer? They're both the same. And this is in the BMJ. This is article about Cross-Kerry's work. What affects our clinical decision making? I think you need to know facts, and recognised as a bit of an old-fashioned person in terms of education. You need to know facts and you need to get experience. And competence isn't enough, it's capability. Being able to manage patients. So there are patient factors. The patient may not give you the whole story. They may not have read the same textbooks that we have, so they present in a different way. There's evidence-based medicine, and we could have a long discussion about that. And then there's your individual clinical judgment, and that's where your thinking comes in. If you haven't read any of François de la Rochefoucauld's stuff, it's brilliant. He basically wrote, I think he was the Stephen Fry of his generation, QI again. He wrote large numbers of very sensible, quite entertaining comments like this. He had 4 wives as well, not at the same time. So what affects our decision making? And this is a scheme that we developed with the Berlin Simulation Centre at the Charité in Berlin for debriefing simulation scenarios, but actually the 4 domains which we've identified in the middle there are completely opposite to decision making. And that was not, we didn't do that consciously, it just happens. So there are technical things, and knowledge and procedural issues are not usually the main things that affect our decision making. The non-technical factors which I mentioned earlier on, which are talks in their own right, are very important in terms of decision making, but for the individual it's how you think and how you reason. We've talked about dual process theory. What's highlighted here are cognitive dispositions to respond. So these are the heuristics and biases, the shortcuts and biases, which are hardwired into our brains. And this is a horrible slide.